Hello, everyone. I'm very grateful that everyone has been coming by. I know it's at the end of our conference, but we're going to make it worth your time. My name is Martin Kraus. I'm from UCSD, and today's panel goes by the title Case by Case, Tips and Tricks to Keep Your Patient Out of the ICU. We have a great panel of anesthesiologists and intensivists today who are going to talk you through perioperative complications you might encounter in the PACU. We'll talk about inadequate muscle reversal, cognitive dysfunction, cardiac insufficiency, and airway obstruction in the PACU. And because of our limited time, I want to introduce our first speaker, Carsten Bartels. He's a professor at the University of Michigan. He's not only trained in critical care, but also at cardiothoracic anesthesiology, pain medicine, and his research is mostly focusing on patient safety, mental health, and also economics in the perioperative setting. He has been published over 120 articles, and it has been supported by the NIH by multiple K and R grants. Today's talk goes by the title Adequate Muscle Reversal, How Can I Avoid Reintubation in the PACU? And with that, with no further delay, I'm going to leave the floor to Carsten.
Thank you, Martin, and thanks for the kind introduction. Thanks for being here on Tuesday. I wanted to talk a little bit about adequate muscle reversal, how I can avoid reintubation. Is it this one? Okay. So first of all, do postoperative pulmonary complications, and I'm going to refer to PPC throughout the talk. Do they actually occur relatively frequently? And this is one of the landmark papers on that, where they looked in more than 8 centers across the US and found that within high-risk non-cardiac surgery, the incidence of postoperative pulmonary complications was about 1/3. Now, truth be told, that included prolonged postoperative oxygen, which they defined as more than 1 day, so it might be a little higher than you would assume if you would use a more rigorous definition of postoperative pulmonary complication. So they're common, but do they matter? Well, this is an old study. It's from 2005, but I still chose to present it because it has really long outcomes. So this is long-term survival after 8 of the most common inpatient surgeries performed in the VA system. And you can see here the outcome, mortality outcome, that's percent alive on the y-axis, goes out to 10 years. And you can see that, for example, for pulmonary lobectomy, after about 2.5 years, only half of the patients are alive. And what was special about this study, they then, in another step, looked at if the patients had a given complication, for example, postoperative pulmonary complications, how did they fare in terms of mortality relative to their peers? And you can see here the purple highlighted line shows a much lower survival probability of those who had a postoperative pulmonary complication in the hospital over time than those who didn't. So it probably matters whether or not you have and whether or not you can prevent a postoperative pulmonary complication. This, I promise, is going to be the oldest paper. It's almost 50 years old, and it describes postoperative pulmonary complications in Denmark using sort of clinical assessment, no head lift, but good eye contact. And they, at that time, found that using a train of 4 ratio of 70%, nowadays they're more tighter, usually at 90%, we consider inadequate reversal, and they had a 42% rate of patients who were weak. How are we doing today? This is a meta-analysis from the mid-2000s using a tighter definition of residual neuromuscular block, mostly 0.9. And you can see the incidence, albeit a tighter definition, is roughly the same. It's still around 30 to 40%. So you could say we haven't made a lot of progress. That sort of stands in contrast about what we think about our own practice. This was a survey where anesthesiologists were asked whether or not they had ever observed a patient exhibiting clinically significant residual neuromuscular block in the PACU, and you can see that more than 80% and even almost 90%, US is always very self-confident, thought that they had never seen residual neuromuscular blockade in their practice. Why is weakness a problem? This is a small but I think cool study because it really shows why it's a problem. They looked only at 38 patients in a weaning ICU and measured grip strength of the hand and then did, with dye, a fluoroscopic exam during the swallowing process. And what they found is that muscle weakness in the hand correlated to an almost 10-fold increase risk in symptomatic aspiration. And you can see here A, that's me now talking, and C is one of those individuals who had the aspiration risk manifest. So it does matter from a practical standpoint. When I started this work, Martin actually led a study at a center where we moved from all neostigmine to all Sugamidex to see if the choice of reversal drug after surgery made a difference in terms of postoperative pulmonary complications. And we did a before and after experiment with fancy statistics. And what that basically means is to chart an outcome of interest, in this case, a composite respiratory outcome that was made up out of either new non-invasive ventilation, so new CPAP or BiPAP, or reintubation, or hypoxic events. And you can see after the dotted red line, when Sugamidex was introduced, we had a reduction in postoperative pulmonary complication. And this study was confirmed by an MPOC study later on with more than 211 hospitals, 22,000 patients that also showed a reduction in postoperative pulmonary complications when used Sugamidex versus neostigmine. However, the data is not completely clear on that. This is a large observational study from Europe, also multi-center, with, as you can see, more than 10,000 patients, and they didn't find any difference whether or not used Sugamidex or neostigmine. Let's turn the tide a little bit and look at PPC incidence in a more recent meta-analysis that was published only last year. And of all the relevant outcomes with Sugamidex versus other modalities of reversal, only postoperative pulmonary complications was lower. However, relevant patient-centric outcomes like mortality, hospital length of stay, death alive and out of hospital, they were not affected. So it still remains to be open whether you reduce pulmonary complications actually affects outcomes, which sort of goes against what we talked about at the beginning of the study in the VA population. I work in an environment where there's still a lot of qualitative and non-quantitative monitoring. Why should we be doing quantitative monitoring? Well, it's this blue little box that shows that if you detect no fade with a qualitative assessment, but do a blinded measure train of 4 assessment with a quantitative monitor, you will find that patients will have high degrees of residual neuromuscular block, even if you think they have absolutely no fade on qualitative assessment. So this is why the new guideline came out in 2023, and it suggests with a strong strength of recommendation to use qualitative monitoring, as well as using Sugamidex for those who have a deep level of block. This has since been sort of taken into action in a large multi-center randomized trial. PRIME-AIR was a study of more than 700 patient randomized multi-center where they did a bundle intervention that included monitoring as well as dedicated protocols for reversal and Sugamidex use, looking at postoperative pulmonary complications. And as you can see here on the columns on the far right on the screen, there was absolutely no difference. Well, that's a disappointment. Why is there no difference? I think this paper just came out 2 months ago in July in anesthesiology, and it looked at inpatient postoperative mortality, so not 30-day or anything. And they looked whether or not these patients were there for an elective versus a non-elective admission. And you can see that essentially all the mortality in this sample of that included more tthan 370,000 patients occurred in the non-elective patients. And that was true for mortality, but it was also true for pneumonia. As you can see, 2% had pneumonia in the non-elective cohort, 0.5% in the elective cohort. There was an editorial with this that was titled, elective anesthesia for elective cases is very, very safe. And that's probably true. So probably, if we do want to further optimize intraoperative muscle relaxation and reversal with an eye on hard outcomes such as mortality, we need to look at non-elective cases rather than elective. So in summary, postoperative pulmonary complications are common, and they are associated with increased mortality. Quantitative neuromuscular monitoring prevents residual weakness. Sugammadex reduces neuromuscular block and may reduce PPCs, especially if you're working in a qualitative-only setting. But whether the focus on avoiding PPCs in all comers actually affects hard outcomes such mortality remains to be seen. With that, I credit my funders and my department. Thanks for your attention.
Thank you so much, Carsten. And if it's okay, we're going to leave the questions to the very end of everyone's presentation. Instead, I would like to introduce our next speaker, Dr. Bangalore from Southwestern, is fellowship trained in critical care. And she's a part of the divisions for critical care, but also transplant anesthesiology. She's also the rotation director for the SICU education of her residents and medical students. And the topic of her talk today is managing heart failure. How can I get my patient off inotropes?
Thank you, Martin, for the kind introduction. Good morning, everyone. The topic is how do I get my patient off inotropes? I'll be focusing on more of the point of care ultrasound to detect the causes more than the treatment of these patients in the postoperative period. I'm going to start you guys off with a case. Here's a 62-year-old male weighing about 130 kilograms with a history of hypertension, diabetes, and a significant smoking history. Comes in with for cystoscopy and percutaneous nephrolotomy. Intraoperatively, just became a little hypotensive after induction. The resident or the CRNA in the room gave some fluids, and now you're called in, has refractory hypertension, gives some vasopressors, no response at all. Eventually responds to some amount of epi, and then gets started on an epinephrine drip. Now the case is done, uneventful. You extubate the patient, but you're still not able to come off the epinephrine drip. The patient comes out to the PACU. The ICU no longer has any beds available, and here you are, and you have to manage the patient in the PACU. What can you do? Kind of looking at what could really be causing these issues. In order to wean inotropes, it's really important to understand what's the cause that's causing it. So kind of breaking into three broad categories here. The first one being cardiac etiology, such as either myocardial infarction, ventricular failure, cardiac tamponade, arrhythmias. Second broad category is pulmonary causes, such as pneumothorax, an embolism, or an effusion. Volume-related issues can act two ways here, such as hypovolemia or hypervolemia, which can solely contribute to the issue itself, or can worsen any of the hemodynamic instability because of an underlying cardiopulmonary cause. It is to be noted that exacerbation of heart failure in most of these postoperative period has been associated with about a 90-day mortality, which is increased. How do you evaluate this patient? Along with a thorough physical exam and lab work, point-of-care ultrasound or POCUS can be an additional diagnostic tool in these cases. Let's start with the cardiac structural assessment. So this is a basic apical four-chamber view, which you can obtain by placing the probe in the midclavicular line along the fourth or fifth intercostal space with the pointer pointed towards the left shoulder as shown here. You get to see all four chambers. You get to see your valves here. You might be able to pick up some amount of pericardial effusion as well. The second view that you could get here is a parasternal short axis view, which can be obtained by now moving the probe along the left of the sternum along the second intercostal space with the probe now pointed towards the left shoulder. You might need to make some minor adjustments based on the body habitus of the patient and along the mid. You can get the view along the mid-papillary muscle. You get to see the left ventricle and the RV here. Might be able to pick up some pericardial effusion here as well. But you can visualize the function of the right or the left ventricles pretty clearly. The other view that you can get is the peristernal long axis view. While keeping the probe at the same spot, now you're just going to tilt the pointer towards the right shoulder. Here you see the left ventricle, the right ventricle, the left ventricular outflow tract, the aortic valve, and the mitral valve, along with the left atrium. So kind of going back to our case, these are 3 views that you can use to detect any kind of wall motion abnormalities, essentially detecting myocardial infarction in this patient. The inferior wall motion abnormality would likely show you a RCA lesion, and then an anterior wall motion abnormalities from either an LAD or the left circumference, depending on how it gets fed by the artery. The posterior wall obviously would be associated with the right coronary lesion with the branching of the PDA or the left circumflex artery. Here in the peristernal view, you're able to see the inferior, anterior, and the lateral, and the posterior wall. This is the only view that gives you all 4 walls. In the apical 4-chamber view, you'll be able to visualize just the ventricular septum, the inferior wall, and the lateral wall, but the posterior wall gets missed. In the peristernal long axis view, you can see the inferior, anterior, and the posterior walls of the left ventricle, but the lateral wall is also not visualized as well here. It is necessary to kind of see the ventricle in all 3 of these views to really hone in on where the lesion could be if you are going to look for a wall motion abnormality, but in general, you're able to look at the function really well when you have all these 3 views. If the patient had a right ventricular dysfunction, you could see some decreased ejection fraction in the peristernal short axis view. Here you can actually compare both the ventricles. You can see the left ventricle and the right ventricle. Septal bouncing is a typical sign that's seen on the left side of the peristernal short axis view, where RV failure is seen, and there's also a small amount of pericardial effusion in the hypoechoic area that you see over there. On the apical 4-chamber view, there's a large right ventricle with RV free wall akinesis, an apical sparing of the RV, especially during its systole. The RV appears like the letter D. This sequel of imaging is commonly known as the McConnell sign. This is what you would see if the patient would have a pulmonary embolism. Tricuspid annular plane systolic excursion, or TAPSE, is a linear M-mode measurement which assesses right ventricular function along the longitudinal axis. So to perform a TAPSE, you need to get an apical 4-chamber view. You place the M-mode cursor along the lateral portion of the tricuspid annulus and measure the distance between the peak and the trough. The distance between the peak and the trough is the TAPSE. Here you could see the severity of the right heart failure. Typically, a normal TAPSE would be about 1.7 centimeters, greater than 1.7 centimeters. That just shows that the tricuspid is able to move freely along the ventricle. As it gets shorter and shorter, the severity of the right ventricular dysfunction also increases. Pericardial effusion could be another cause of an ongoing inotropic support in our patient. In the apical 4-chamber view, if you were to have pericardial effusion, you would see a hypoechoic area around the heart. The larger the size of these effusions, you can present with cardiac tamponade. This is where you see the right ventricular collapse due to compression effect with the fluid around the ventricle, resulting in a filling defect and eventually causing hypotension. However, it is to be noted that the cardiac tamponade is more of a clinical diagnosis, and POCUS should be used as an additional tool and support for your decision-making rather than a confirmatory tool. Another cause of heart failure that would necessitate any kind of treatment with inotropic support might be acute mitral regurg, which gets largely undiagnosed unless you have any invasive monitoring or TT. Here's an example of severe mitral regurg. Again, you'll need to get a peristernal long axis view, and with the color Doppler, the color flow mode, you can see that there's reversal of flow back into the left ventricle. Again, a classic sign of regurgitation. Any discussions around cardiac dysfunction is incomplete without evaluating for pulmonary causes. Lung ultrasound can be used to quickly diagnose the most common perioperative concerns such as pneumothorax and pulmonary effusion. To assess the lung, we can either use a transthoracic or a curvilinear probe. Again, it depends on the body habitus of our patient. In our patient, likely will need the curvilinear probe with an obese patient. Here's a lung ultrasound in the B mode. On the left is a normal lung, and on the right you don't see any lung sliding, which is indicative of pneumothorax. If you don't see any lung sliding, with 100% sensitivity, it could detect pneumothorax. If the patient does have tension pneumothorax, you would obviously have issues with your peak pressures, but there could be decreased preload to the heart, which could also result in cardiac dysfunction requiring inotropic support. Here you can see the jellyfish sign, a classic finding on pleural effusion where the collapsed lung is swimming in fluid. To obtain this view, you'd have to be along the mid-axillary line or about the 8 intercostal space. And this patient likely had some heart failure, had increased volume. We don't quite know, but whatever the etiology is, this is one quick way to diagnose it. In addition to the cardiac and pulmonary causes, like I mentioned before, the volume status is extremely important in these patients that can either independently contribute to poor function of the cardiovascular hemodynamics or can exacerbate any other cardiac manifestations. So we could switch gears and look at the inferior vena cava. It is an indirect estimation of the pressures in the right atrium, which correlates well with the core volume status. In the subcostal view, the 2D view here, you could place a probe in the subxiphoid space along the pointer in the cephalad direction, and you'd be able to get the subcostal IVC view here. And the hepatic vein, about like 1 to 3 centimeters from the entrance of the IVC to the right atrium, is where you'll be calculating the diameter. If the diameter is less than 2.1 centimeters and the collapsibility is greater than 50% during inspiration, it's considered to be a normal finding. Your right atrial pressures are about 0 to 5 millimeters of mercury. However, if the diameter here is greater than 2.1 centimeters and the collapsibility is less than 50%, it correlates with higher pressures, likely hypervolemic patients, and the right atrium pressures are somewhere around like 10 to 20 millimeters of mercury. To allow for easier measurements, I mean, you could use M mode so that the respiratory effects of the respiratory changes are not affecting your calculation. So you could do a transverse or on the left or the longitudinal view on the right. The white arrows show you the maximal diameter and the black arrows show you the minimal diameter, depending on which equation that you use here. If the distensibility index is greater than 12 or greater than 18, you likely have a fluid responder in a hypovolemic patient. I'm going to show you a little clip here of, this is a patient with low core volume status. The IVC is fully collapsible, indicating that the patient likely needed some more volume. On the right here is a fully plump IVC, decreased collapsibility, likely has hypervolemia. Left ventricle outflow tract is another assessment for to check your volume in a patient. As shown here, you can get the LVOT on the long axis view or in the apical 5-chamber view. Using the LVOT, you can calculate the stroke volume. I'm not going to go through all these equations here. It's just here for teaching purposes, really. But it's easy to measure the left ventricle outflow diameter in the long axis view as shown here. You take that and you get your LVOT area using this equation here. The LVOT area is pi the radius, which would be half of the diameter here. And the apical 5-chamber view, you would get the pulse wave Doppler along the LVOT gate, and you kind of trace along the wave here to get the VTI, and you use the VTI in the LVOT area to get the stroke volume. Once you have the stroke volume, you're able to calculate your cardiac output depending on the heart rate, but you do have the caveat here as a patient has to be in normal sinus rhythm or not have any signs of aortic regurgitation. Kind of taking you back to the case. I mean, with this patient had multiple comorbid conditions, really it could be any of the reasons that we just went over that could be leading to the patient requiring inotropic support. So really, POCUS becomes an excellent tool in managing the hemodynamics of the patient, especially in someone who's required any kind of inotropic support in the postoperative period. We'll leave for questions.
Thank you so much. So what I suggest is that we just do the questions at the very end of the case, and then instead of moving on. So Dr. Saeed is going to be next. She's an assistant professor at the Cleveland Clinic. She's also critical care trained, and she's currently the director at the surgical ICU at the Cleveland Clinic. She's also the past communication committee chair for SOCA and SCCM. And her talk today will be focusing on airway obstruction in the PACU and if her patient needs CPAP or not.
Good afternoon. Thank you for attending. I'll be focusing on patients that you might find in the PACU that are presenting with obstructive symptoms, and this talk will focus on evaluation as well as how can we prevent these events from happening to our patients. So starting off with our case. So we have a 65-year-old male, has history of obesity, hypertension, OSA, chronic respiratory failure, on 2 liters of chronic oxygen at home, and is presenting for a pancreatic mass resection. We get done with the case, we put him on a simple face mask, and he's off to PACU. But then you get the dreaded phone call, hey, he's not looking good. He seems very sleepy, but he's also in 10 out of 10 pain, and he's kind of sounding like having noisy breathing as well. And they let you know they put him on a non-rebreather, and his SATs are 91%. So what do you do for him, and how do we evaluate this person? So starting off with, as we talked about earlier, PPCs, he obviously has a lot of risk factors. And one of the biggest things is he's got general anesthesia, which obviously alters his pulmonary physiology, his cardiovascular physiology, his muscle function. And we want to know what the modifiable and non-modifiable risk factors are, preferably in the preoperative period, so we can actually maybe potentially optimize him. So common definitive risk factors are, as we know, major abdominal surgery, upper abdominal surgery, neurosurgery. Anybody over the age of 65 is at higher risk. ASA 2 or anybody ASA 3 or higher, having major cardiovascular or respiratory issues preoperatively. And then there are potential probable risk factors that have been identified in literature. General anesthesia versus regional or neuraxial techniques tends to maybe have more risks. Having a resting PaCO2 at home of 45 or higher, coming into surgery with an abnormal chest x-ray with a URI is obviously kind of putting the patient at more risk. And then in the postoperative period, the use of NG tubes has been associated with an increased incidence of perioperative respiratory complications. So obviously, since our patient's obstructing, he's obese, this talk is going to focus on one of the more common pre-op conditions we see, which is sleep apnea. This is a common disease, and the prevalence has been increasing, and it's seen more in men versus women. 7 out of 10 patients that are presenting for bariatric surgery may have OSA, and then when they've looked at other patient populations, such as general surgical, orthopedics, the rate is anywhere from 2 to 7% in these different populations. And one of the biggest issues with OSA is that it may be undiagnosed. So how do we go about identifying OSA? It's a pretty complex disease process, and it can have a very heterogeneous presentation depending on disease severity, as well as what are the coexisting comorbid conditions. Diagnosis can start off in the office with just a conversation with the patient focusing on signs and symptoms such as obstruction, presence of snoring, any witnessed apnea events, and then on exam looking at their anatomy such as having a large neck, large tongue, enlarged adenoids or hypertrophied tonsils, especially in the pediatric population. And also looking at any previous anesthetic history of difficult mask ventilation, difficult intubation. In the office, the easiest tools we have to use are validated screening tools such as the Stop Bang questionnaire, the PSAP, Berlin questionnaire, ASA checklist. All of these have been validated and can potentially identify patients at high risk. But then the next step is generally a sleep study, which is not always convenient to do, but it is the gold standard. In the sleep study, they measure the apnea-hypopnea events per hour, and then based on the number of events, patients are classified as mild, moderate, or severe OSA. And the classification is important because the patients with the severe OSA, they have the highest risk of having cardiac arrest or severe cardiovascular events in the perioperative period. This algorithm was published in 2019 by the AHA, and they kind of try to simplify how should we be evaluating this patient. So the easiest one is our pre-op patient that has OSA, that has had a sleep study, and is using his CPAP and is compliant. They can go off and have their surgery and use their CPAP in the perioperative period. But the patients we get presented with are that present to surgery that have risk factors that maybe have not been diagnosed or have been diagnosed but for multiple reasons may not be able to comply with their CPAP therapy. What do we do with these patients? And I think the AHA wants us to kind of look at, they do not recommend canceling surgery, but they do recommend looking at what are the coexisting comorbid conditions and are they uncontrolled. And the ones they highlighted were severe pulmonary hypertension, uncontrolled heart failure, And the third one they identified was having resting hypoxemia, which is symptomatic and not treated. So if the patient presented with these and there was time to optimize, these were the patients they said, hey, you need to maybe hold off, have them sent off to a pulmonologist, maybe do a cardiac evaluation and see how we can further optimize them. They will have the highest risk. But if they did not have uncontrolled conditions, then their recommendation was let the surgeon and the patient know, hey, you're at high risk. We can proceed, but we have to take some common sense measures. These patients are the ones that may need continuous pulse oximetry and continuous telemetry to monitor them. They may need a step down or a higher level of care depending on the invasiveness of their surgery. And then they need to be monitored until they're kind of back to their baseline condition, and they may need new PAP therapy post-operatively. So these are things to kind of discuss and talk about in our pre-op evaluation. So moving on to perioperative management. So if you look at the guidelines, the last guidelines that came out from the ASA were in 2014, and this was with the Anesthesia and Sleep Medicine Society as well. And they focused on the following: airway management and medications and kind of common things that we expect. Guidelines that have come out after have basically built on these, and they have not necessarily added anything very new. And the main thing to know about these guidelines is the level of evidence is pretty low. Majority of these recommendations are from consensus, from experts, and then from narrative opinions. So for airway management, the recommendation is to follow the Difficult Airway Society guidelines using common sense measures such as ramping the patient, using pre-oxygenation, maybe doing apneic pre-oxygenation with high flow to buy yourself more time. With hypnotic sedative medicines and opioids, the recommendation is to give the minimal, most effective dose and to avoid long-acting medications or continuous infusions. And for neuromuscular blocking agent, this is the population where if you have residual neuromuscular blockade, they would have the most kind of adverse events in this group, and to reverse these patients completely when they have received neuromuscular blockers. In terms of anesthesia technique, recommendations are to do these if the surgery can be done under a neuraxial technique, regional block, to perform these surgeries with that plus moderate sedation. And if you have the option of general anesthesia versus deep sedation, they recommend doing general anesthesia with an established airway over deep sedation in these patients because of their high risk of airway collapse. And in any kind of sedation case, there's recommendation to use continuous capnography, which we routinely use. Emergence from anesthesia is recommended in a non-supine position, semi-upright, not maybe lateral, but not try to avoid having the patient supine if possible. So what do we do in the PACU? So if these patients have post-operative pain, again, the recommendation is to go for regional techniques or blocks if possible, and to use multimodal agents other than opioids, and to avoid continuous infusions of opioids. And if you are using continuous infusions, to really consider placing them in a higher level of monitoring, for instance, like a step-down area. For supplemental oxygen and pulse oximetry, these were the only areas where there was RCT evidence available, where providing supplemental oxygen in bariatric surgery patients which weren't diagnosed versus those that were diagnosed found that they had the same rates of adverse events. So this was one where there was actually more data. Patient positioning, again, should be non-supine if possible. And then if they have a CPAP that they were using at home, this should be continued in the perioperative period. At our center, the bariatric protocol actually has CPAP built in for nighttime use. So going back to our case, we get called, we evaluate the patient, we look at their intra-op record, and you want to look at everything, what opioids they got, how much fluids they got, because they may have this noisy breathing. It could be sleep apnea and obstruction, but it could be other things like stridor, fluid overload, so you want to rule everything out. We get an ABG, and it shows they have a respiratory acidosis that's non-compensated with hypoxemia, with a little, like a mild elevation of lactate at 1.5. So we can kind of go down their history, see if they actually use their CPAP, did they bring it in. We can go towards more imaging, such as getting a chest x-ray, which might give us an idea if they have atelectasis or maybe aspirated or have fluid overload. And then, as Dr. Bangler pointed, ultrasound's a great tool if you have it available. You can quickly look at the lung, and it has higher sensitivity than your chest x-ray for a lot of these lung pathologies. And then finally, if you needed more information, a CTP protocol would give you more detailed information about the vasculature of the lung. So you looked at all these things and you think this is obstruction. How do you go about managing it in your PACU? So First, we look at, does this patient have a condition that is amenable to, using non-invasive, and there's data for it. And yes, they have obesity, they are probably hypoventilating, they have OSA. Other conditions where you can use non-invasive for is COPD exacerbation, heart failure exacerbation, and generally for primary asthma exacerbation or severe pneumonias, it's not generally indicated. In those cases, those patients frequently, if they have a severe exacerbation, need to be intubated or monitored in an ICU setting with BiPAP because they tend to deteriorate and tend to have more multi-system organ involvement. So other things to consider when we are thinking about non-invasive is, are there any true contraindications? Is there any facial deformity? Did they have a big ENT flap and you can't put this BiPAP on them? Are they really acidotic and altered, and they're not really going to comply with your therapy or be able to pull off the mask if they aspirate? So all these things should be considered. And if they truly look like they're impending respiratory arrest, that's somebody you want to call the ICU early, potentially intubate early. Red flags would be if you started your non-invasive therapy and they're not improving, they're still tachypnic, maybe getting worse from a mental status standpoint, and that's when you really need to think about intubating them early. In terms of setup, you can start off patients, if they have a known prescription, you can start them off on their known prescription. But if they didn't have a known prescription, then you can start off with an EPAP of 6 to 8 with IPAPs in the 10 to 12 range. But the key thing whenever you start somebody on is to look at their output on your ventilator or your BiPAP machine. Are they achieving that 7 to 8 mils per kilo, which will help them improve their hypercarbia and hypoxia? If not, you may need to dial up all those settings. And especially in the PACU, it's important to coordinate with your nurses, your RT, to make sure, they make sure the patient's sitting up. If there's big leaks, now they have gels and devices where they can attach to the mask to cut down on those leaks. So there's things we can do to optimize our BiPAP therapy. I hope I gave you some tips on how to get your obstructive patient out of the PACU. Thank you.
Thank you so much. Our next speaker is Dr. Pai Cole from the Stanford University. She's a full professor, and she's dual trained in cardiothoracic as well as critical care anesthesia. She also is running the grand rounds of her department, and she's very passionate about educating not only critical care and cardiothoracic ICU, cardiothoracic anesthesia, but also TEE. And she will talk about cognitive dysfunction today, and we're very grateful for her because she actually had to jump in for another speaker who had a family emergency, so we're very much appreciative that she could make it. Thank you.
Thank you for that kind introduction. I hope the family situation's okay. Okay, so my topic today is disoriented and restrained, and we're talking about perioperative delirium. I have no financial disclosures, and why don't these slides move? Okay. The objectives today are twofold. One is how do you identify people who are at risk for perioperative delirium, and what strategies can we use in the perioperative period, meaning in the OR as well as in the PACU, and furthermore in the ICU. It's a big problem. It affects 10 to 65% of patients who are presenting for high-risk surgery. It's a very expensive problem because it changes the mortality statistics for our surgeon. It increases length of stay and increases cost, therefore, and it changes home dynamics because more people end up going to a non-home discharge. Furthermore, it is an independent predictor of long-term cognitive decline. If you look at the US Census reports, the people over the age of 65 are living longer, and therefore they are going to present for more surgeries around you. We recently did a 102-year-old TAVR. Just as a throwing it out there. What are the outcomes? So one of the biggest papers that has come out in the space is the ESA-EEC, or the European equivalent of the ESA, that's looked at over 2,000 references and has looked at not just basic science and outcomes, but also what things work and what things don't work, along with the role for both rehabilitation as well as prehabilitation, if you will. When you look at long-term outcomes in the ICU, anybody that has delirium is going to stay longer in the ICU. And that goes to say then that they're going to stay longer in the hospital as well, not just as a function of more ICU days, but more days on the floor as well, because they need to be placed, they need things at night, et cetera, et cetera. And interestingly, in cardiac surgical populations, the incidence of perioperative delirium is associated with a higher risk of mortality, which is actually quite frightening. We all know about preoperative risk factors at this point: age greater than 65, someone who is sicker, meaning who has an ASA classification greater than 2, someone who has more comorbidities, or Charlson comorbidity index greater than 2, and then a mini mental state examination of less than 25, indicating pre-existing cognitive decline. Some surgeries, especially long, bloody surgeries like cardiac surgery, which is associated with cardiopulmonary bypass, along with thoracic and vascular surgeries, urgent, emergent surgeries, anything that disrupts the circadian rhythm for the patients, or especially our elderly patients, are more associated with delirium. And medications that we think about using routinely in the OR, whether they're benzos or anticholinergics such as Benadryl. Some of these patients have had transplants and are on steroids, and we give them steroids. My colleagues just presented airway drama, so you give them steroids. That also causes them to rage and therefore have increased incidence of delirium. Is that it, though? There is a role now for AI to look at predicting it in the preoperative space. So this is a tool that was developed in Switzerland. It is being validated in various centers, including ours, where basically this tool will go into the chart, into your EHR, and it will look for these 9 sort of elements, including age, body mass index, ASA classification, prior history of delirium, prior history or history of cognitive decline, number of medications they're on, preoperative C-reactive protein elevations if it's available, surgical risk of cardiac events, meaning big bloody procedures where you're at risk for MACE, and then laparotomy or thoracotomy status. And what it does is it gives you a percentage of what your risk, not yours, but your patient's risk is for perioperative delirium. And this is being validated. What it does is it doesn't give you a silver bullet, really. What it does is it identifies these patients, and we use this not just in the pre-op space, but this is also part of our checklist, which we're sort of doing as a pre-op checklist in the OR. And what that does really is it sort of highlights or brings to your attention that there are things that we can do perhaps differently so that we can mitigate this problem for our PACU and our ICU colleagues. The biologic basis is more complex. Definitely, there's neuroinflammation. We know this, I think. It's not very strong evidence. It's a signal, if that. There are various people that are looking for particular filaments and blood tests as well as CSF tests. This is all animal studies that look to see if having any of that preoperatively and then having it increased postoperatively makes the person at risk for delirium. One thing that we definitely know is about sleep disruption, and we know this from our own practice. If we're post-call and we've had a busy night, we're more likely to have conversations that we may not remember later. So that I think is very well known. So restoring sleep is a very important part of delirium management. What about specific things we can do in the OR? So when you look at dexmedetomidine versus placebo, meaning no drug, then definitely in the non-cardiac setting, there's a role for reduced incidence in perioperative delirium. Now, this is not a prophylactic thing, but this is when it's used in patients who are at higher risk of having post-op delirium. However, this does not pan out in the cardiac surgical setting because these patients have multiple hits, if you will, in being delirious. Jesus. What about other drugs? And what are these other drugs? So if you look at propofol, benzos, morphine, et cetera, all of them, again, dexmedetomidine is protective against delirium in non-cardiac surgery. In cardiac surgery, it's sort of mixed, but some people think that there is a role. And there's a large variation even in my own practice, where some of us use it right from the get-go and some of us use it later. So I don't think it's very convincing in that space. What about depth of anesthesia? Is it that the older patient has a very low, say, processed EEG number, which makes them super likely to have delirium? Well, this was 800 patients, over 800 patients, and this was a Canadian study. It's called Engages, published in JAMA, which saw no difference between EEG-guided anesthetic versus not. So I'm telling you more things of things that may not help, but it gives you more information for what it's worth. How do you diagnose delirium? It is definitely an acute onset of mental status change or a fluctuating course, along with inattention. You would gauge inattention by having the patient in a PACU in this delirious state sort of squeeze hands when you're holding them, every time an A is uttered, either in the Save Heart or in Casablanca. And if they make more than 2 mistakes, they are likely to be delirious. And in that case, you would ask them questions to figure out whether they have disorganized thinking, meaning, if I throw a pebble in the water, does it sink? Yes, no. So very simple questions, but this is sort of, and this is the ICU delirium chart, and this has been translated into over 12 languages, so it's available in various iterations in patients who have language difficulties. And finally, using a altered level of consciousness score, whether it's a RAS, et cetera, also helps to get you to where you can figure out whether they're delirious or not. Of course, delirium comes in 3 varieties. Hyperactive, very easy to diagnose. That's the person who's screaming. It's very rare. It's more likely in younger people. It's easily identified and easily treated. Hypoactive is the most dangerous one because that's where they get ignored because they're not causing a problem. It's more likely to happen in our older population. And then, of course, there's the mixed group as well. What are things we can do? Identify patients and then include the family in this space. Help with reorientation, help them with glasses, help them with hearing aids, help them, familiar voice. If they're not available in person, having video calls also helps. Restoring sleep cycles. That's the most important thing in this space. We have what's called a nocturnal awakening prevention protocol. It's called NAP. And you can order that on the floor for all patients who are not at risk for decubes. So keep that in mind. There are some caveats. And basically what it means is that the nurses are not giving the patient a bath at like 2 in the morning and turning them with all the lights on, et cetera, which has happened. What about early mobilization? Another very key component. We had a buy-in from PT groups is very important, especially within 24 hours of surgery. And then the patients have to get out of bed twice a day or every shift with our nurses. Things we need to identify and treat, we've talked about this: dehydration, anemia, infection, pain, and constipation. Very important. Stopping drugs which cause delirium. There's a long list, which is not I don't have all of them on here, but things that I commonly think about in our space are opioids, especially Demerol, Tramadol. All of them cause more delirium. Benzos, anticholinergics, and again, steroids. So hopefully I have provided a whirlwind tour of how to identify perioperative delirium as well as strategies that can be used to mitigate it. Thank you.
Thank you so much. Are there any questions in the audience? We have plenty of time. Everyone was very compliant with the time limit. So if there are any questions in the audience, it's a good time to step forward to the microphone or just speak up. That's also fine. Actually, I had a couple of questions to the audience. At your institutions, how many people actually have quantitative twitch monitors available in the operating room? Yeah, like in every operating room, or?
That's a standard.
We have them, but I do mostly cardiac surgery cases, so if you don't get it in right before the patient's arms are tucked, it's sort of not a thing.
Yeah.
We do get dinged because we participated in MPOG, so there will be it shows up to say you did not do this and compared to your colleagues. So we're trying to remember, and our residents have gotten really good at it. So yes.
It's actually very great, but it kind of looks like that the majority of institutions, after all these years, not really like having engaged. And I feel like with the introduction of Sogamedex, it has gotten even harder because I think a lot of people just feel subjectively that it's very easy now to safely reverse a patient. So that was one of the questions. And then I wanted to ask how many in the audience or in the panel here, how many preoperative clinics routinely scan or do screening tools for obstructive sleep apnea, such as stop bang or others? Looks like most of you guys, yeah.
It's perfect.
And how about like opioid naivety? Because we have, we recently, like I think Dr. Kana actually published a paper how there's a so-called prodigy screening tool where you can actually also look into if opioids, if patients are more likely to be opioid naive and more likely to obstruct. Is that anything the preoperative clinics at your guys' institution? Doesn't look like it, okay. Maybe some questions for the speaker panel. Dr. Paikol, you talked about how you have this order set, it looked like it was epic, to kind of reestablish or like to reinforce the nocturnal or the circadian rhythm. Has your institution actually looked at, after implication of those bundle, have they actually looked into outcomes? This is mostly ICU, also post-operative delirium. It looked like anyone can order it.
Anyone can order it. We're starting to look at it. We have to remind each other to sort of do it more frequently because if it's not ordered, it's not done.
Yeah.
And so we haven't started looking yet, but it's sort of on our list.
Yeah, it looks like it's going to be the next step after. Yeah. Perfect. Go ahead, yes.
I just had a question for Dr. Syed. And for those patients who present with what you think is a lot of risk factors for obstructive sleep apnea, is heated high flow as good or an alternative? And what is sort of your trigger to go for either one?
So we do use high flow, and patients tend to like it better than having a mask. So I think it depends on the degree of acidosis and their clinical exam. If they're awake mostly and kind of respond to me and their pH is not, less than 7.25, I'll give like the high flow a little bit of a trial. And we use the high flow, which is the aerobic, the 60 liters. And if you look at the studies, there's some like taught that like the high level of flow will give you like about 5 of PEEP. So maybe it'll splint over the airways. But I think once we're doing the high flow, you have to kind of monitor and see, is the hypercarbia kind of staying stable? And then as they recover from anesthesia, they're hopefully going to take some deep breaths and kind of bridge themselves over. But if they don't, if the hypercarbia is worsening, then we, take out the BiPAP or CPAP and start there.
And do you have this, also, the RTs, can they easily deliver it to the PACU as well, or is it mostly like an ICU thing?
So we can do high flow actually in the PACU, and we actually have high flows for the OR, especially we've been using them for awake fiber optic oxygenation, pre-oxygenation strategy as well. So they have a very portable one with less of the wiring in the OR. They can bring it to your OR.
Perfect.
We can even extubate after it if we feel like if it's needed.
That's fantastic. Dr. Mangalore, you talked about point-of-care ultrasound. Like in your institution, and this might also be a question to everyone, frankly, but do you have like a phased array probe, like an ultrasound probe, easily available in the PACU? I remember when we both worked at Denver, we actually had a resident on their rotation in the PACU, and there was actually emphasis made about point-of-care ultrasound teaching. But I was just curious what the availability is in your institution and overall in the audience.
Yeah, we do have a bunch of equipment available. We have at least 2 or 3 that are on standby, and the portable butterfly probes, our residents use that for POCUS curriculums, like you said. They're around. Most of us that do ICU like know where to get them, so it's a little bit more easier. I do think with the OSCE including the POCUS curriculum to their testing now, a lot more resident interest in POCUS, so like there's always someone around to do something, so it's never been a problem. Obviously kind of beyond the scope of this talk, but we've been using it for gastric ultrasounds a whole lot with this new age of like Ozempic and Mounjaro and things like that. So that's been kind of taking up most of our POCUS rotation than the other most of the cardiac stuff that they really like to do it in like patients that are in the ICU because they want to practice on the patients that are vented and easier to control things. But there is definitely a change in practice, I would say. Even when I was a resident, we didn't get this much of an exposure to POCUS, but now it's like part of their curriculum starting as an intern year.
Shifting a little bit away from cardiac ultrasound, since you mentioned transgastric, do you feel like has it changed like the management in these patients who haven't been taking, like who have continued to take their medication?
I use it a lot in pre-op sometimes. Our pre-op clinic is excellent at getting most patients through, but we do have some services that are still kind of hesitant to send them through. One of you guys mentioned it was like the non-elective cases that had the highest mortality and the AKI, like those are the ones, so, the ASA4s, and as one of the ICU faculty, we tend to do more of the ASA4s in my institution, so we use this a whole lot. Sometimes you don't have an echo, you don't have a BNP, like they just show up from the ER, it's like, acute belly, like you get a quick exam. I think just like the 4 views, especially for the heart, the apical 4-chamber view, if you're able to get there, or like a subxiphoid view, one of those 2 things will give you enough information to like induce the patient safely. The other thing that we have been using now is non-invasive monitoring with the new LitGo, which just hooks onto, as long as you have an A-line, you get SVR, cardiac input, the index on the output. So that's another thing that we tend to use for the most part.
Very interesting. Yeah, come.
Just the precedence in the post-op delirium, is that starting pre-op, inter-op, or is it treatment for delirium, and then was it infusion, or was it, some of my colleagues would go 4 or 8, like a small dose?
Oh.
How is it administered, and what was it effective?
10 minutes is never enough to talk about everything you want to talk about, but thank you for the question. The Precedex, it's an infusion, no bolus, because they're definitely, with boluses, there's definitely a higher incidence of bradycardia. So as an infusion, I would only administer it, so full disclosure, my practice is cardiac surgery, so I use Precedex when I'm putting in A-lines. I do awake lines for the transplants, so I'll do Precedex there instead of benzos and opioids, and while you're waiting to hear. So that's like you can turn it off if the organ isn't viable, for example, and no more than 0.4 in awake patients, and then 0.7 to 1 in patients who you're gonna intubate as well. And that's my practice even for the ICU. We do what's called DEX cycling. So we start DEX at 10 p.m. and we take it off at like 4 a.m., sorry. And the idea is that they can't go to the floor with it, so there needs to be a different strategy for when they're going to the floor. So we'll start guanfacine, which is a PO version of Precedex, and that takes about 3 days to kick in. So we'll do Precedex 10 p.m. to 4 a.m., and if they persistently need it past 2 days, then we'll start them on 10x, which is guanfacine, and they can go to the floor with that. And all our ICU patients are on Romeltion, which is the precursor and the cleaner form of melatonin, as well as daridorexant, which is I think Belsomra is the other cousin of that same drug, if you've seen it. All non-addictive, sort of restore the sleep cycle, very clean. And so we try to stay away from things that, cause problems later. So no trazodone, no Benadryl, those kind of things.
Since we have a couple more minutes, Dr. Cole, the EEG study you cited, did they use raw EEG data, or did they use a processed, I don't want to mention any company names, but was it was like a proprietary index, or? Gotcha, yeah.
It was actually very cool because like when I was a resident, they would say, oh, the number is 20, so they're never gonna wake up or whatever it is, or they're gonna DIE or whatever it is, right? So, sorry, I'm superstitious. So that's why I tried. That's why that study was so great, because it's like, okay, well, there are reasons why that number may be low, but it doesn't. Particularly when it comes to delirium, it really doesn't have much of a signal.
Yeah. Okay. Are there any more questions from the audience? If not, I want to thank you again to this amazing speaker panel, and I appreciate the audience and the discussion, and for sticking around this late in the conference. Thank you.